Yeah. Okay. Thanks again, and nice to be with you all this afternoon for this virtual session on biometry. So I'm going to just give you the salient features on how would you go about refining toric IOL so that your outcomes are much better. No financial interest in any of the products mentioned during the course of this presentation. So I'll be outlining how you would go about refining in the four aspects of toric IOL planning and execution: preoperative phase, the marking phase, the intraoperative period, and in the postoperative sections here. So first is the decision making on the IOL which you're going to be choosing or needing for the patient here. When you're planning a toric, and if you find that there is a discrepancy or your biometry is not satisfactory, perform it over a range of instruments here, and so that you would be able to compare the magnitude and axis of the IOL power which you've selected for your patient over a range of devices, and that would help you to sort of narrow down which would be the best one to use for your patient. And now, as most of us have switched over or moved on to using premium IOLs, it would be a good idea to use your sweat source OCT or your image guided options for in your preoperative planning here. Various types of preoperative markings. You could move over from the conventional two-step or the three steps marking. A simple slit lamp marking also works well here. Once as a surgeon you're experienced to do it yourself and you know to tailor your results and you've been able to correct your flaws, then that works fine as well. Otherwise, a simple pendular marker or your bubble marker works just as well. Looking at the meta-analysis, of course, the image-guided systems afford a better accuracy, narrowing it out to the depths of 0.1, 0.2 diopters, which is available there. But we still do not have IOLs which can cater to 0.2 or a 0.1 difference. We do still work at a 0.5 level difference with our IOLs here. But definitely an image-guided image captures preoperatively and intraoperatively will help to enhance and refine your toric results. What we do have in terms of preoperative devices is the Bevion and the Callisto here. And in the intraoperative, you have the intraoperative aberrometer for recording your refraction in real time and basing your IOL placements based on the imaging you get. They all work on the simple principle. There is a preoperative reference image which is superimposed on the intraoperative image using landmarks, and this graphic overlay guides you towards a better placement along your target axis in all your cases here. So that's how we work on the IOL alignments here. Most of these systems also have additional usage on planning your incision sizes and placements, but most of us are now doing sub 2, so this is not a huge advantage which you're here, but it can help you with your capsular axis size if you want to. But what's more important is focusing on the pre-existing ocular surface health here. Identify a dry eye, treat the dry eye, and call the patient back on a different sitting with a different technician who's going to perform, or you perform yourself, but when you're having variations in your keratometry because of a poor ocular surface here. So that's one aspect which you need to take care to refine your results in patients here. Of course, the intraoperative imaging gives you a real-time imaging when you have the luxury of using an Aura. And that can give you both aphakic and postoperative pseudophakic refractions, and you could place you could choose your IOLs if you're having a load of inventory here to pick up the right IOL over the one which you have planned, which would be a great help in refining your results here. Or you could also vary your axis and your cylinder on how your Aura is showing the intraoperative imaging. So here's one such patient here, and once you are able to position, once you've done your phacoemulsification, it captures the aphakic refraction in the Aura, and once you put in your IOL, you can repeat the imaging, and the imaging will then tell you how to rotate the lenses in your patient, and it's a whole battery of suggestions, and you would learn to pick up the one which would be the right for a better better results in your patients when you're refining your toric results. I think I'll just rush into show you a few examples of patients here. Here you have here you see a significant cylinder which you would like to correct with your torics, and your Barrett's is giving you a T3. The Varion is giving you a T3 here, but the Aura is give you a T4 here. So that's how it helps you to refine when you're using an image guided. When you don't have the Aura, I still feel the Barrett's is a better option. A second option here where the Barrett's gave me a T4, the Varion also gave a T4, and the Aura was also going on bang on giving you a T4, then you know your accuracies. A simple method postoperatively is to image on your tracy refractions or on your ray tracing methods using an eye trace, which would help you to locate and say if your postoperative positioning is inadequate, especially in patients if your visual acuity is a good method of assessing how if your postoperatively your IOL needs a. These are operative images on Aura once you have positioned the IOL and once you have rotated into a position and captured an imaging, which it tells you where no further rotation is required, which means you've gone bang on to what has been calculated. Yet another example here of the patient where the Barrett's gave a T4, the Varion gives a T5. So these are situations which are a little confusing here, and your Aura goes on to T3. So again, this varies with the against the rule and the with the rule astigmatisms you need to correct. So understanding those aspects are going to be really important. Sometimes your eye trace does show huge rotations here, and if it is coinciding with the visual acuity of the patient postoperatively, you would want to refine going back and rotating your IOLs. But you don't need to rotate when you have a 2 degrees or a 5 degrees and your visual results are good. You do not need to go back and rotate your patients at all. So the important pearl is measure correctly always and place correctly. So these are the two most important pearls when you're tackling toric IOLs, so that you will be able to get good outcomes, and you will be able to refine your outcomes to the optimal levels in patients. The importance in this is that there is a cyclotorsion in the patients, and this results to untoward surprises, especially when you are having patients with against the rule and when you have higher quantums of astigmatisms, which you need to be correcting here. Always take into account posterior corneal astigmatism is now of significant importance. So use some of the newer generation devices when you're planning your torics or premium toric IOLs here. And those will help you to get a better result. So the true K component is now incorporated into most of the softwares and in most of the latest biometric devices, and they help you to give you a better astigmatism. Where you do not have a posterior K incorporated, then always try to corroborate the anterior K with your refractive astigmatism, which gives you a better idea of what's going to be the quantum of the posterior cornea, and especially if you are going to be worried if your against the rule astigmatism is going to be higher, because you know the posterior cornea is has an against the rule astigmatism. Most of us have now moved to feeding in a centroid value of 0.1. Some use 0.2, but we do not use the conventional 0.3 in our calculators when we are feeding in the SIA. So there is a subtle shift in the centroid value used for your calculations, which can also enhance your results here. Postoperatively, remember the long-term astigmatic drift which can occur on the ocular surface here. So you would probably want to leave your plan in such a way you leave about a 0.3 with the rule astigmatism. That's another way in which you can probably refine here. So again, remember with the rule astigmatisms over 1.5, and if you do have a significant against the rule astigmatism on the anterior corneal surface, then that's an indication where you probably need to relook at your results and refine them as well. And if you've gone, just take half a minute more here. And if there if the patient is visual outcome is not optimal, then simply dilate, look at the positioning. You can use a simple slit lamp, the slit beam and the rotator there to locate, or there are a series of softwares, smartphone softwares in which the image can be put in and look at and use it for guiding you for rotating the IOLs, or the astigmatismfix.com. It's another site which will help you to refine your results in case of postoperative surprises. Thank you again for your patience here.